Kathya Alonzo, and today's topic is going to be about low-dose methotrexate for the prevention of atherosclerotic events. Definition: inflammation is closely related to atherothrombosis. Treatment with canakinumab, a monoclonal antibody that inhibits inflammation by neutralizing interleukin 1 beta, result in a lower rate of cardiovascular events than placebo in a previous randomized trial.
Arteriosclerosis. There is an apparent coronary artery network in the human heart. On a zoomed view of one of the coronary arteries, 3 layers are seen. These are tunica externa on the outer, tunica muscularis in the middle, and tunica interna layer at the inner. When cholesterol, found as LDL molecule in the blood, is carried at high levels for a long time, these cholesterol molecules precipitate on the artery's surface. Then it leaks through the gaps of the epithelial cells. They form a deposit in between the tunica interna and the tunica muscularis layers. This fatty deposit is called plaque. As the plaque grows bigger, spreading in the artery, it bulges in the lumen, forming a lump, and this reduces blood flow. This is called atherosclerosis, also known as hardening of the arteries. With time, epithelial cells may split at a point. This situation activates platelets and enables the formation of fibrin thread. Clot forms as a result. This clot is known as thrombus and prevents the blood flow in the arteries.
Application in medicine. Low-dose methotrexate is an inexpensive, effective, and widely used treatment for inflammatory conditions, including rheumatoid arthritis, psoriatic arthritis, and juvenile idiopathic arthritis. Also, in observational studies, patients with rheumatoid arthritis and psoriatic arthritis who receive low-dose methotrexate have fewer cardiovascular events than patients who receive other therapies or placebo.
So the cardiovascular inflammation reduction trial, for me, is fascinating because at first sight, the implications are, here's a negative trial. But actually, it tells us something really interesting about the biology. We know that the IL-1 beta, IL-6 pathway from the inflammasome is implicated on the basis of the previous CANTOS study. Now, here's a different approach without selecting individuals at high CRP. Using amount of methotrexate that was sufficient to influence the hematological markers, but it did nothing. And it did nothing to the IL-1 beta, IL-6 pathway. So I think that this tells us that that pathway is crucial in terms of modifying inflammation and plaque behavior.
I was surprised it didn't lower C-reactive protein, and Dr. Richter is the PI. So why did Dr. Richter choose a drug that doesn't lower C-reactive protein to test? But it certainly is a nice trial to show that you can't just use any old anti-inflammatory drug. You have to use ones that meet specific pathways. And certainly with the results of the CANTOS trial, the IL-1 pathway appears to be the one to approach. But it didn't disappoint me or discourage me about the idea that directly targeting inflammation can still be beneficial for cardiovascular patients.
I think that with each of those trials, we've got to specifically look at that pathway. And we've got to look at the questions of, is the extent of dose sufficient to modulate that pathway in the plaque? Because if not, we may be facing another negative trial. There have been some interesting trials with colchicine already that look encouraging, but they were small.
And so I would like to have some sort of direct anti-inflammatory agent that has been demonstrated to help cardiovascular patients available to my patients. And then I'm also excited about the LODOCO 2 trial because colchicine is inexpensive. It's been shown to be very safe. It's already used for not only treating gout, but for treating other cardiovascular things such as atrial fibrillation and pericarditis. And so it might just fit right in if it becomes evidence-based by the LODOCO 2 trial. So I'm excited about that. And I'm also excited about other agents that might be targeted now that people know which direction to go. There have been other anti-inflammatory agents that have not worked. And so now we might have some that will work, especially now that we should probably concentrate on the IL-1 pathway.
Pros and cons. The pros are that the methotrexate is an inexpensive, effective, and widely used treatment for inflammatory conditions. But the cons are, first, that the methotrexate did not lower interleukin 1 beta, interleukin 6, or C-reactive protein level. Also, it was associated with elevation in liver enzymes levels, reduction in leukocyte counts and hematocrit levels, and a higher incidence of non-basal cell skin cancer than placebo.
Canakinumab is a selective human monoclonal antibody against interleukin-1 beta, a pro-inflammatory cytokine that has been implicated in the development of atherothrombotic plaques. Increased interleukin-1 beta activity leads to elevated levels of high-sensitivity C-reactive protein, or CRP, a biomarker associated with an increased risk of coronary heart disease. Previous trials have demonstrated greater cardiovascular benefits from statins in those with elevated levels of high-sensitivity CRP before treatment, and when lower levels of high-sensitivity CRP are achieved with treatment. However, it remains unclear whether reducing inflammation without lowering cholesterol would prevent cardiovascular events. Investigators tested this hypothesis in the large double-blind CANTOS trial, which enrolled patients with a history of myocardial infarction and high-sensitivity CRP levels of more than 2 milligrams per liter. 10,061 patients were randomized to 4 groups: subcutaneous injections every 3 months of 50 milligrams of canakinumab, 150 milligrams of canakinumab, 300 milligrams of canakinumab, or placebo. At baseline, the median LDL cholesterol level was 82 milligrams per deciliter. Throughout the trial, patients in the canakinumab groups had significantly lower high-sensitivity CRP levels than those in the placebo group. LDL cholesterol levels were not reduced with canakinumab. The primary endpoint included non-fatal myocardial infarction, non-fatal stroke, or cardiovascular death. The median follow-up was 3.7 years. After adjustment for multiple testing, the 150 milligram dose of canakinumab, but not the other 2 doses, significantly reduced the rate of the primary endpoint. Rates of neutropenia, thrombocytopenia, and fatal infection or sepsis were increased with canakinumab treatment. The authors conclude that targeting interleukin-1 beta with canakinumab at one of 3 doses every 3 months reduced atherothrombotic events, independent of lipid lowering. Full trial results are available at nejm.org.
Issue applied in Ecuador. In Ecuador, data reported by the INEC 2010, it was evidence that in overall the mortality rate from cardiovascular disease was 1/22 persons, and specifically on ischemic heart disease present our general rate of 1/14 persons.
Your arteries, a system of tubes that transport blood around your body. Over time, the buildup of fatty material can damage and clog arteries, restricting the blood flow. This is known as atherosclerosis and can lead to heart attacks and strokes. There are several causes, including high cholesterol, which can clog up your arteries over time, high blood pressure, which can damage areas in your artery walls, making it easier for fatty material to build up over time, and smoking, The chemicals in tobacco smoke can also damage arteries, leading to this fatty material buildup. If a fatty deposit breaks down or ruptures, a blood clot can form around it. This can block your artery. If this artery supplies blood to your heart muscle, it can cause a heart attack. If this artery supplies blood to your brain, it can cause a stroke. There isn't a cure for atherosclerosis, but thanks to British Heart Foundation research funded by your generous donations, we are understanding more about how to treat it. The good news is that you can do something to slow down its progress, and the earlier you start, the better.
Conclusion. Patients with stable atherosclerosis, low dose of methotrexate did not reduce levels of interleukin-1 beta, interleukin-6, or C-reactive protein and did not result in fewer cardiovascular events than placebo.
Atherosclerosis refers to a condition in which plaque gradually builds up in the wall of an artery. When fatty deposits containing cholesterol enter the blood vessel walls, immune cells are sent to the site to collect these fatty deposits and transform them into hard plaque. This causes the walls to thicken, meaning less blood can flow through them at a time. Atherosclerotic plaques are visible as bulges along the affected artery and can rupture and form blood clots within the arteries.
Thank you so much for watching.